Myself, I am not a poet. I am very happy to bring these CMEs to you. I introduced Dr. M L Kalra. Dr. M L Kalra is a senior physician at Max Panchi, MD Medicine from Rohtak. Much before I went to school and came out of school, sir had already finished his MD. And sir is one of the most respected physicians in the group. I request Dr. M L Kalra sir to introduce Dr. Aparna Jaswal ma'am and to introduce the topic and to take the CME forward. 784th, ladies and gentlemen.
Friends, I am deeply indebted to PFI and Dr. Chauhan to give me a chance to moderate today for a talk given by none other than my favorite. I call her my best teacher. Of course, we are senior to her in age, but her way of giving a CME is much different than all others. Majority of our speakers, they come and it's a one-way dialogue. They deliver their message, but here we have a lot of interaction. She is different. About the number of CMEs PFI has given, I noted that we are one away from the magic number 786, Billa number 786. So we are very close to that. Coming to today's talk, the speaker, my favorite, Dr. Aparna, and we have heard many times. This is sixth time we are listening to her talk. I won't go into many details about her academics. To introduce her is just like showing a candle to the sun. We all know. We are so close to her in so many involved CMEs also. We have met her. She is presently working as Director of Cardiac Pacing and Electrophysiology at Fortis Heart Institute. She had a glorious academic career during undergraduate and postgraduate. She was trained in electrophysiology at St. Luke's Medical Center, Milwaukee. And she was certified at IBHRE as a device specialist in 2007 and recertified in 2017. She has been having a keen interest in implantation of cardiac devices, ablation of arrhythmias, and a particular interest among arrhythmias in the ablation of ventricular arrhythmias. She has been actively involved in management of patients of heart failure and atrial fibrillation, both. She has been mentoring young electrophysiologists for the past several years and has been actively involved in IHRS services and as a board member in USA. So I won't take much time. I will invite her to give her talk. The topic today is CRT. Who are the candidates? एक छोटा सा एग्जाम्पल देना चाहता हूँ कि आप गाड़ी चला रहे हो, अगला पहिया एक साइड का पंक्चर हो जाए तो क्या होता है, या गाड़ी की अलाइनमेंट बिगड़ जाए तो क्या होता है, गाड़ी ठीक से चलती नहीं है, you have to get it realigned or set the puncture so that all the vehicles, all the wheels, they move in right direction, in coordination, synchronized. Otherwise, your car will not be moving in the right direction, rightly, and you are likely to accidents. So, I welcome Dr. Aparna.
Good evening to all of you. It's indeed a pleasure to be here. And let me clear my stand once before I begin, and on two accounts. Dr. Chauhan gave a very kind introduction of me, and you also mentioned that I'm here for the sixth time and waiting for support from you. Let me stand corrected here. I don't think that I have come here hoping for support. All of you have already given me so much support by being here, showering the love and affection which Dr. Kalra just mentioned. I think coming here is just worthy to hear those words. So let's take it from there, and the fact that we're all together is what's important. If I can convey the message and make you understand the need of what I'm going to speak is worthy of my visit. The rest can all follow, and trust me, it does. So I think, thank you so much. So I think it's not appropriate to directly go into, just as Dr. Kalra said, that it is not my forte to just throw the slides upon you and get back home. We are here for a message. We are here to understand what is happening in heart failure and how together all of us at every end of the pyramid can come together to heal the patient. Because I think all of us are just looking for that. How do we heal the patient? Each one has a very important role in trying to deliver that. And as my mentor, Dr. Saxena, I must tell you, and I want to take a break here and let you know that. All of you know Dr. Anil Saxena, and he's my mentor, my teacher, and I have great regard and respect for him. So when we're sitting on our lunch and you see that, you read about a doctor who is working in the inskirts of some village and he has healed so many people and done so well, I go to him and tell him that, what am I doing? I'm so selfish, I'm working for myself, I earn my money and I go home. To which he says, which I have caught hold, and I want to tell it here, because each one of us must remember this, that he tells me each time that when you come to work and you do your work sincerely and deliver your best, you have done the best act of the day. And this applies to each one of us in the pyramid. We are sitting at the pinnacle of pyramid in premier institutes, but it is you who's sitting at the base, in the middle and at the upper end, where we deliver healthcare. And if each one of us understands this subject well, it's a task well done. I think many before me would have come and spoken about heart failure. When you open the chapter of Braunwald and read heart failure, the first sentence it reads is, heart failure is relentlessly progressive and an unforgiving disease. Because when somebody is diagnosed with heart failure, you can see the graph. Look at the red line. It is intuitive, the patient will die. And the patient's life is going to be abbreviated because heart failure is unforgiving and it is relentlessly progressive. What is it that we can do to change the natural history of heart failure to our country? The people in our country, the population at our country is even more troubled because heart failure steps in 10 years earlier. We have more comorbidities and we have lesser economic support for our patients, which is right here, which you will understand. So if we want to see heart failure around the world, this is a graph which I have taken out from the Paradigm HF trial. I'm sure all of you are aware about the molecule called ARNI. So ARNI, and all of you would have listened umpteen articles about ARNI in heart failure. This is from the Paradigm HF trial. I want you to look into this slide because this is a very important slide, and this is a slide of heart failure hospitalization per 100 patient years. Look at the hospitalization in Thailand, Japan, Taiwan, and where is India? India is at the ebb low. Lowest admissions of heart failure in India because we have maximum out-of-pocket costs. So it's glaring at us that while heart failure in India is very high, people are unable to admit simply because patients have to pay out of pocket, and we understand the problems there. However, good news is around. The medical therapy has changed the natural history of heart failure. You as physicians, I'm sure, all of you know the foundational 4 drugs in heart failure. The foundational 4 drugs are beta blockers, MRA, ARNI and SGLT2 inhibitors. You must remember every time you see a patient of HFrEF, is my patient going home on this prescription? You must count them on your fingers. The issue remains that despite guideline-directed medical therapy, all of us know about it. You would have heard several speakers before me come and speak about the need of guideline-directed medical therapy. But look here, those patients who were followed in a heart failure clinic by cardiac electrophysiologists, in them 66% received guideline-directed medical therapy. However, those patients who were not followed by a heart failure clinic, a 44% received guideline-directed medical management. Coming back to the point that I made, in the pyramid, each one of us has to intervene to bring the best outcomes of our patient. So you have to engage yourself and give the foundational 4 drugs for your patients of heart failure. The latest guidelines. And guidelines is something which I urge you to read. They make a very good read at bedtime. Open up the guidelines of heart diseases. They are very nicely written papers. So the guidelines tell us clearly that when you give medical management, your patient remains symptomatic, you have to bring cardiac devices in. Now I set the stage for cardiac devices. When we talk of cardiac devices, today my task is to speak on cardiac resynchronization therapy. When we speak on cardiac resynchronization therapy, Dr. Kalra very well brought out what happens to a car if one wheel goes off. Well, surely, and there's an animation to that, it will never be steady. So we have to do something. We can only do something with a CRT when you see that there is evidence of electrical dyssynchrony on a patient's EKG. Let me put it very clearly. When I see a patient of HFrEF, heart failure with reduced ejection fraction, if I see an ECG with a wide QRS, I feel good. I can do something for that patient. If I see a HFrEF with narrow QRS, I feel bad because I cannot do anything for that patient. So you should remember that whenever there is electrical dyssynchrony, which is seen by you on an ECG with a wide QRS, it implies that you should think, can I do something more for this patient? The reason you need to do something more is this. When your patient has a normal left ventricle, this is how it is supposed to contract from the base to the apex, synchronized. But when your patient develops electrical dyssynchrony with left bundle branch block, this is how it will be. It will become globular, it will be dysynchronous, the lateral wall of the left ventricle will be last to activate, and that's a problem. When your patients develop left bundle branch block, and this is the left bundle, this is the sinus node as Dr. Chauhan mentioned, the sinus arrest, this is the sinus node, this is the Bachmann's bundle. Is there a pointer by any chance? So this is a Bachmann's bundle, there are interatrial tracts, this is the AV node, the bundle of His, the right bundle, the left bundle. When your patient develops a left bundle branch block, it implies the electrical activation of the left ventricle is delayed. As a result, the mechanical contraction of the left ventricle is delayed, as a result of which the patient develops dyssynchrony and goes into heart failure. Now, how do I assess? Is my patient a candidate for a device? As I mentioned, when your patient develops heart failure because of dysynchronous contraction of the left ventricle, as he just mentioned, there are several methodologies to identify which is the patient for a device. It could be an ECG, it could be an echocardiogram. I'm sure many would have come and spoken to you about this echocardiogram, spectral tracking, global longitudinal strain, septal and lateral wall, E by E prime ratio. But thankfully, the simplest modality to identify a patient for CRT is just the ECG. When I entered electrophysiology, it was ECG, then there came echo. Finally, we understood echo is no good. We have to only go back and see the ECG, and the EF should be less than 35%. That's all that you need. To put the concept, how did this all begin? So, it was in the year roughly around 1994, about 30 years ago, it was thought that patients needed something. They went ahead and gave a pacemaker with 4 leads. So what did they do? They gave 1 lead in the right atrium, 1 lead in the right ventricle, 1 lead in the left atrium from the coronary sinus, and 1 lead epicardially on the left ventricle. What does that mean? The only way you can reach epicardial is by doing a sternotomy or a thoracotomy. How morbid that was. Putting a pacemaker with 1 lead in the RA, RV, 1 through coronary sinus and epicardial. But this laid the foundation. This said it works. if we pace the left ventricle, it works, which led to the randomized controlled trials and telling us as doctors that there is a way that you can enter the left ventricle without opening up the heart, opening up the chest or thoracotomy. What was that? The coronary venous system. Now, when you were doing your MBBS or I was doing my MBBS, the emphasis on this venous system was very minuscule. We just read in the anatomy textbook as a passing mention that there's a coronary venous system. What is this coronary venous system? You know, the superior vena cava brings blood from our upper body into the right atrium. The inferior vena cava brings deoxygenated blood from the lower part of the body into the right atrium. The coronary venous system brings the deoxygenated blood of the heart into the right atrium. We identified there was a way to enter the coronary venous system and activate our left ventricle. This is the cut section of the heart which tells you, and you should know, when we go in to the coronary sinus and pace the left ventricle, I put the lead from the right atrium and enter this point. This is the coronary sinus. When I place my lead in the coronary sinus, what do? This is the coronary sinus. I position my lead into the lateral veins. You're seeing how superficial those veins are. So we go and pace the left ventricle epicardially. Remember, they are very thin-walled structures. Veins are always very thin-walled structures because they have no muscle in them. Thus, the foundation was laid that you no longer need to go in such a morbid fashion epicardially, but today we are doing CRTs, everything transvenous, endocardial. So transvenous because we use the venous system, endocardial because we go inside the heart. A right atrial lead, a right ventricle lead, a lead through the coronary sinus into the lateral or the posterolateral vein. It could be a CRT-P, which is devoid of a defibrillator, or it could be a CRT-D, which is having a defibrillator inbuilt. How did we conclude that it works? It was not just on one trial. There have been multiple randomized controlled trials. What does randomized mean? Patient does not know, the doctor does not know, and we give one a device and one no device. So the value of randomized controlled trials is very large, so to say. So you can see all the ones that are in yellow and then they have those green check marks are the ones which worked favorably for our patients that they should be given CRT. We concluded, and they were about, in all of these trials, they were about 15,000 patients total. So they were small trials but randomized trials. So we concluded that if your patient on echo has an ejection fraction of 35% or less, you should think of CRT. If the patient is in heart failure, think of CRT. If the QRS is more than 120, think of CRT. So what are the criteria? I told you, only EF less than 35 and a wide QRS and NYJ functional class 3. However, it changed. Now if your patient has EF less than 35, has any symptoms of heart failure and has a QRS which is wider, we are no longer taking 120, and I don't want to go into these trials. But what these trials basically told us, they told us that CRT works. CRT does much better than heart failure. So if you look here, if a patient was given CRT versus optimal medical therapy, look how widely the graphs are diverged, telling us that CRT helps in reduction of cardiovascular death and hospitalization for heart failure in a statistically significant manner when given to patients who have EF less than 35%, have a wide QRS more than 120 to 150 milliseconds. That's what we had learned. However, we subsequently learned by another trial that when you want to give CRT, it should be given to patients who have EF less than 35%, have symptomatic heart failure, any symptom, and should have a left bundle branch block with a QRS of more than 150 milliseconds. So then the stage was set. Now, this slide is busy and I'm not going to go into that. All it's going to tell you is that the guidelines have been evolving over time. The first guidelines for cardiac devices came out in the year 2008. Subsequently, they have been aggressively modified. They have been modified because we are learning more. I showed you several randomized trials. Today we are becoming smarter than what we were a decade ago. And we have learned from these guidelines, and the latest guidelines that we follow today are the European guidelines of 2021, and in 2022, that's this year, we've had the American guidelines. I urge you, whenever any subject you want to read, not CRT, always go back to the European guidelines. European guidelines are more conservative. European guidelines are a very good read. They make a very good understanding. American guidelines, while they be followed in significant part of the world, are very aggressive. Americans want to go ahead on and put devices and do everything everywhere. So follow the European guidelines. So now I will take you through, I'll just now rush into the few cases that I have, and I have set the stage with clarity now that patients who have left ventricular dysfunction should be offered CRT if they have a left bundle branch block. In the next couple of minutes, we'll try to discuss with a little more clarity as to when do you want to give a CRT and when do you want to give a CRT-D or a P. I'm not going to go into too much the thickness of things, but I'll give you a broad overview. So we have a 70-year-old gentleman who's undergone a bypass surgery, has significant left ventricular dysfunction. I want to bring this point very clear here, that if your patient has ejection fraction compromised, means EF is less than 35%, you should really worry. If the patient's EF is less than 35%, his risk of sudden cardiac death is very high. Let's talk of KK today. I think a lot of noise came in. We were all on NDTV talking about the singer KK's death. So what happened to him? He had a sudden cardiac arrest. Lots talk of Shane Warne. What happened to him? He had sudden cardiac arrest. So why did KK die? I mean, he died because he probably had a myocardial infarction on stage and he had a ventricular arrhythmia and he died. There could be another reason, that he had some basic, he probably may have had small myocardial infarction in the past and he never knew, and he started throwing ventricular arrhythmias and he died. So what I'm trying to imply, if your patient has LV dysfunction, EF less than 40%, you should really worry. You should think that should this patient be evaluated? I want him having Holters done. I want to see whether he's at risk. So here is a patient who has very severe LV dysfunction, has symptomatic heart failure. The reason I bring this out, he is on optimal medical therapy, ARNI, beta blockers, SGLT2 inhibitors and diuretics. MRA has not yet been added. Every slide will carry this to reiterate the foundational four. So, here is a patient who has symptomatic heart failure, has EF less than 35%, has an ECG which shows the QRS is more than or equal to 150 milliseconds with a left bundle branch block abnormality. I have said this is a patient who certainly needs a CRT. So what is the recommendation? The class of recommendation with level of evidence is class 1A. EF less than or equal to 35%, I told you. QRS more than 150, left bundle branch block, you must consider a CRT. Now the question which comes is, you should be smart enough, not the electrophysiologist alone. You should not buy what the other doctor says. Should he give CRT-P or should he give CRT-D? So the answer here lies that this is a patient who qualifies for a CRT-D. Why? Those of your patients who have ischemic heart disease should be given CRT-D. Those of your patients who have DCMP, non-ischemic, can be given CRT-P. I don't know how many of you all aggressively use cardiac MRI. As cardiologists, we are aggressively using cardiac MRI for identifying any scars in patients who have non-ischemic cardiomyopathy. So we don't need to go into that, but basically ischemic heart disease needs CRT-D because there will be myocardial fibrosis on MRI. Look at the ECG after CRT. This is the ECG before CRT. Look at the wide QRS. Look at the QRS after CRT. If electrical dyssynchrony was the reason, we have resynchronized the ventricle. It is as good as a normal person's ECG. Similarly, we'll go to the next case. 58-year-old non-ischemic dilated cardiomyopathy. The first case was post-CABG, ischemic. Non-ischemic, severe LV dysfunction. When you see the number less than 35%, you should be worried. The patient can just go any day. And the patient is on beta blockers, ivabradine and diuretics. She has been withdrawn for ARNI and SGLT2 inhibitors. The reason being, the patient has a raise in creatinine. Another point I wish to highlight to all of you as practicing physicians, just like you write name, age, sex, hypertension, diabetes, the next thing you should write creatinine clearance. Unless you write creatinine clearance, you cannot offer the optimal medical therapy to your patients. So you should write creatinine clearance. So this patient had this ECG. Again, look at the ECG. It is white. The QRS is 150 milliseconds. Again, this patient has a left bundle branch block. Look at lead 1 AVL. There is no Q, there is a tall R and V5, V6. So this is a dilated cardiomyopathy. You have understood you want to give a CRT because class of recommendation is class 1. But now what do you want to do? A CRTP or a CRTD? Because financial, it's not just the financial component. Finances, anyway, it is double CRTD. It is also an impact of the patient's lifetime. CRTD are complex devices, thick devices, they can trouble the patient. So in this patient, you can probably get away giving CRTP. Reason? It's a non-ischemic cardiomyopathy. She did not have any myocardial fibrosis on her MRI, so she deserves a CRTP. That's how you should think. And I bring this up for you to see on this animation. This is what a CRTP looks like. This is the lead in the right atrium, right ventricle. Be able to identify for yourself. A dual chamber pacemaker will have one lead in RA, one lead in RV. A biventricular pacemaker or a CRTP will have RA lead, RV lead and one more lead going via coronary sinus into the epicardial coronary vessels. And remember, the X-ray chest. Actually, this device will have a radiographic signature of the industry. Supposing the patient comes to you and you need an orthopedic surgeon tells you that I need to get the pacemaker interrogated. You say, which is the pacemaker? The patient often will say, I don't know. If you look at the X-ray carefully, you will see the radiographic signature of the industry. Medtronic will have its own signature on it. Today, there are apps. You can download that app on your phone. If you open that app and you place your phone on that pacemaker, the app will tell you what pacemaker make this is. How interesting is that? And that's the animation, the video that I showed you of the CRT, and look at the ECG. How rewarding it is when you transform the ECG from QRS duration of more than 150 to less than 80 milliseconds. It is absolute delight as electrophysiologists. The day is made when you see an ECG such as this. So now I'll just run you through. You've already understood CAD, you've understood poor LV function, you have understood heart failure, and the patient is on optimal medical therapy. You know the case is strong. All you want is the ECG. Now remember here, this is an ECG with right bundle branch block. Whenever you see a patient with LV dysfunction, heart failure, but a right bundle branch block, now you begin to think, should I give or not? In these patients, you should give because they are class 2A. You can consider giving them, may be reasonable giving them because they are non-LBBB, symptomatic heart failure. It is ischemic heart disease. I told you in ischemic heart disease, you want to give a CRT-D. Why am I showing you this? I am showing you this video from my lab, the cine from my lab, because this cine, I know it's not working, the defibrillators are larger than a CRT-P, and I wish it worked. I don't know why it's not working. Yeah. The reason I want to show you this is that you yourself can identify that this is a CRT-D on X-ray. So these are simple things which you should take home. A CRT-D lead will be a thick lead. You will suddenly see an ugly looking coil here, but this is the life-saving coil. When you give a defibrillator here, we always give on the left side, and this is the RV lead, which you can see is in the RV myocardium here. Now, defibrillator, as the name implies, defibrillates the heart. How does it defibrillate the heart? You are aware when you defibrillate from outside, you put one paddle on the sternum and the other on the apex. Here, it defibrillates between the can and this ugly looking coil. So the coil and the can encompass the myocardium such that the energy traverses across it. I have told you in the past, I am certain, but I want to tell you again. These defibrillator devices are big and bulky, although they've really become small over the years. The reason being, when you put your finger into the electrical socket, how much volt do you get in India? 220 volts. All of us at some point in time have faced that, and we suddenly eject our hand. With a device like a defibrillator to save a human life, the patient can receive as much as 600 to 700 volts. Imagine, that little device can give 700 volts to revive the patient. That is because in ventricular fibrillation, what happens? There are several circuits acting inside the myocardium. You need big energy to stop all the circuits. So you must understand that these are very powerful devices, a medical marvel by Michel Borowski to bring it into fora for our patients. So you've understood LVBB, QRS more than 150, LV dysfunction, CRT. Anybody who has RBBB, QRS more than 150 may be reasonable. Similarly, if you see another patient who has non-ischemic heart disease, has compromised kidney function, creatinine clearance is 36. Now comes a problem. The patient had syncope while sitting in the office. So in India, when we see patients of LV dysfunction and syncope, we say you need a defibrillator. No, they don't agree to that. They want that, how do you know I had a VT? They don't agree that you need a defibrillator. So often we depend upon what we call the loop recorders. So this patient did not agree, so we send the patient on a loop recorder. When we send the patient on the loop recorder, this is what we see. He has a monomorphic ventricular tachycardia. You can see the rapid heart rate is fast, it is wide complex, a monomorphic, and it is identified as VT. So the loop recorder revealed the patient had ventricular tachycardia. You saw that the patient has a RBBB with a QRS which is 120 to 150. So now I will not spend time. This patient is class 2B, but clearly this patient deserves a CRT-D. He had VT, he needs ICD, and this patient should be given a CRT-D. This animation is only to show you again what a CRT-D looks like. One lead in the right atrium, right ventricle, and the third lead in the right ventricle, in the left ventricle via the coronary sinus and the epicardial coronary vessels. Now when you see an X-ray chest, you will be able to identify simply by looking at the RV lead, and if you see this coil, you know you're dealing with a defibrillator. So this is the post-implant ECG. Look at the post-implant ECG. How beautiful this post-implant ECG looks. It really makes the case worthy. So I don't want to go into each of these, and I don't want to go into the nuances, but I surely want to show you the last case, which is this one. So this is a young man, and I want to draw your attention to this because whenever you see young people needing a pacemaker, what is young? Anybody less than 50 years of age needing a pacemaker, you should really think, why does he need a pacemaker? Does he have an infiltrative? Because needing a pacemaker, a heart block, is a degenerative disease as we get older. But if young get it, it could be an infiltrative disorder. And today we have MRIs, we have PET scans where you can identify disease. So look at this young man. This is a very interesting case, and recently I dealt with him. He's 49. When he was 35, he developed heart block and he was given a pacemaker. It's called a VDD pacemaker 10 years ago. He had normal LV function. He was doing very well on pacing rhythm. He came to us from Assam because he had a syncope. He had several syncopal spells, and he brought along with him a Holter. Look at this Holter. Even you can make out that there is a spike and there is QRS. Spike and QRS. But at some places there is a spike and there is no QRS. Spike and there is no QRS. If this happens, the patient will have syncope because the pacemaker is not working correctly. The pacemaker is not pacing. It is giving a spike, but it is not pacing the ventricle. So the patient will have syncope. So when he came to us, we did his echo. His echo showed from 55%, his ejection fraction in 10 years became 25%. The echo showed a suspicion of sarcoidosis. Now, the ideal modality to identify sarcoid is a cardiac MRI. But this patient had a pacemaker which was 10-year-old, which was non-MRI compatible. So MRI could not be done. So we sent him for a PET scan. A PET CT identified that he had sarcoidosis, and of course we identified that his current pacemaker was not working well enough. So what did we do for him? This is what we did for him. As you can see, this patient had a VDD pacemaker. This is a single lead. If you can identify, this is a lead which is going into the right ventricle with a VDD pacemaker. So on a VDD pacemaker, we see that, what is this that I'm trying to show you? I'm trying to show you what we do in the lab. We go in the lab and we identify which vein are we going to target. What a beautiful vein after entering the coronary sinus. I now want to position my lead there. That's how I go and I position my lead into the coronary sinus, and you can see it here that the lead has gone into the coronary sinus and it is nicely poised there. So this is the old lead, this is the new LV lead, and this is the new defibrillator lead. We gave him defibrillator because he had sarcoid LV dysfunction. These patients can throw VTs, hence we did this, and this patient truly needed a CRT-D. Remember, if your patient is on a pacemaker and he develops LV dysfunction, he needs a CRT. Keep that in your mind clearly. Pacemaker, LV dysfunction needs a CRT. So I want to conclude that the American guidelines are very aggressive. We follow the European guidelines. Whenever your patients come with LV dysfunction, EF less than 35%, QRS which is wide. When we say wide, we mean a QRS more than 130 milliseconds. You should at least begin to think, does he need a CRT? If the QRS is wide with left bundle branch block, he clearly needs a CRT. If the patient's QRS is wide with right bundle branch block, it may be reasonable. Please seek opinion from your friends, from your colleagues, and offer the patient the treatment after having given him optimal medical therapy, as I described the guideline directed medical therapy. I think I would like to conclude here. Thank you very much. If you permit me a minute. So, please be here, sir. No, be here, sir. So, I want to show it to you. I must have shown you in several forums. This is the ECG machine, and this ECG machine is a single lead ECG machine. Today we have the same ECG machine, which is a 6-lead ECG machine, and we are going to do a study all over the country trying to pick up 5 lakh ECGs with this machine. This can take 6 lead because it has 2 electrodes here and 1 electrode in the back. This can also work as a 12-lead ECG. So that's the wonder. One more moment I will take. All of you are aware that this is a pacemaker. I think everybody knows that this is a pacemaker today. And a CRT looks very much like a pacemaker. CRT looks like a pacemaker. Now you should remember, for those of your patients, science is so aggressively going forward that for those of your patients who don't qualify for CRT, like I told you, I feel bad, their QRS is narrow, there is nothing for them. Today we have devices which have come in, and this is this. This is not a pacemaker. This is called cardiac contractility modulator. So science is very aggressively trying to heal human, making us live longer. So if CRT is not there, maybe in my next session when I have, this may have already been approved by the FDA and into the guidelines. This is called cardiac contractility modulator. I just wanted to show you some of these newer devices. Thank you very much.
Friends, I think you all agree it was a mesmerizing talk. We wished she keeps on talking on and on. Loved your talk. Thank you so much. Please give once more big hand. To make the forum light, I will ask a non-medical question first. Dr. Aparna, जब कोई ये कह रहा हो कि जब दिल ही टूट गया, हम जी के क्या करेंगे? So is a patient for a cardiologist or mental health or both? I'm also pointing to a medical question related to this. What to do for a broken heart syndrome? Does our CRT or any of the device work there?
So actually, is this working? Yeah. So let me tell you that there is something called Takasago's disease. So that's a reality that it has been noted. If you, especially in women, if they are in a dire stressful condition, they can develop heart failure, which is reversible. But yeah, this is a fact. So, and also I believe, like, I'll give you an instance. While today we were on these forums talking about KK Singh's death, so repeatedly this question came up that can stress cause heart disease? Can stress cause heart attack? Can it cause heart failure? And the answer is yes. Stress can cause, and all these, it's not something funny. I mean, you're absolutely right that there is a medical connotation, because stress is known to be a pro-inflammatory condition. A pro-inflammatory condition predisposes us to diseases and can also result in strokes, which could be brain stroke or a heart stroke. So you have a very pertinent point there, that yes, it can happen.
Yes. As you said, there were 3 major criteria, like EF less than 35, QRS more than 120 milliseconds, and the stage, whatever you say,
Heart failure.
heart failure, yeah, symptomatic.
Yeah.
So are there minor criteria also which add on or which may ease the major criteria to some extent, like as you said, the creatinine clearance? Maybe diabetes also, does it matter if one is having diabetes uncontrolled or whatever? Will it matter?
I think that's a very, very valid question, and let me put it and give you the answer in the perspective that whenever we identify a patient who has heart failure, ejection fraction less than 35% with a wide QRS, we think, okay, this is a patient I would consider a CRT. Now, it has been well known that to have the response, patient is spending out of pocket, he's spending good amount of money, you want to be sure whether it's going to work. There are certain pointers which tell us that I should be more cautious and I may not be rewarding the patient as much. For instance, if the patient has atrial fibrillation, the success of CRT may not be as much. While sinus rhythm, the success will be more. Presence of significant mitral regurgitation, the patient may not have as much success. The presence of a very large scar, supposing the patient is an anterior wall MI or anterolateral MI, the success of a CRT may not be as large. While if the patient has a wide QRS, left bundle branch block, EF less than 35%, I am very happy. A diabetic patient, I am very happy. I want to heal him because his heart failure is going to be progressive. So these pointers come together and tell me that yes, this is the patient I will give and this is the patient I will not give.
My last half question before I give mic to Dr. Tulsi, who is very eager. Just wanted to know, like defibrillation is like an, say, I would say, I can say, जैसे हम mania में देते हैं ना, shock. So it's a shock therapy. So if a person is having defibrillator, if I shake hand with him and incidentally he gets a shock, so will it affect me? Should I say namaste to him instead of shaking hand if I know that he is having defibrillator? What's your take on it?
I think this is probably the best question you have asked. And whenever an ICD is given, we have an Indian Heart Rhythm Society. And Indian Heart Rhythm Society is battling this point that defibrillators should only be implanted by electrophysiologists simply because this question which comes, the follow-up of a patient of a defibrillator should be done by an electrophysiologist. Why? Because imagine if he is awake and he gets a shock. 700 volts is a killer if he is awake. And if he has a family member next to him, I mean, we may not be at that point in time, but a family member is touching him, the family member will also get the shock. So what happens is, we have seen patients getting shock after shock and the family members will also be awake, leaving him alone because the shocks will be transmissible. So you need, while an ICD is a lifesaver, we understand that the programming of an ICD is very crucial and imperative that it be done in the right formatting. There are some patients who, if receive shocks when are awake, they come to us and tell us, Dr. Saab, I would rather die, but I want this device out. I don't want to live. They have such a huge psychological trauma themselves that they urge the physician to remove the ICD. So you have a very valid point on that.
So in the meanwhile, I pass on the mic. Question, is it reusable? Like we use the cadaveric heart for transplantation, can it be used if a person dies, he was using device, can be reused to someone else?
Yeah, so So ideally it can be used, but typically in clinical practice we don't remove it and give it to another patient for medical legal reasons. Because if you give it and if the device fails, it becomes the physician's responsibility. If you give it and it gets infected, it becomes the physician's responsibility. So while it can be done, and we have done it in a minority, and places like All India Institute of Medical Sciences could potentially be doing it. We in fact tell our patients that please go and donate it to All India Institute because they have the bandwidth to handle such situations. A private setup does not have the ability to handle situations of a device failure. So that's why, but it can be potentially used.
So, Dr. Aparna, what a pleasure to listen to you always. Lot of things to learn. At the outset, let me say, I'm neither a cardiologist nor an electrophysiologist. I'm just a general physician. And if I ask you some very primitive and simple questions, kindly pardon me. Okay, so Dr. Aparna, what has changed from the 2013 guidelines? Pacing after syncope, pacing after TAVI if needed, pacing after if you have infiltrative and inflammatory heart disease, pacing induced cardiomyopathy, we are going to talk about that probably later on, and of course the CRT for heart failure, conduction abnormalities. Yes ma'am.
So let me start from the last one. So what's changed from the previous guidelines in CRT is they have given more clarity. They have told if your patient has left bundle branch block, and I have significantly emphasized upon that. The previous guidelines also said left bundle, but they said QRS more than 130. The current guidelines say clearly left bundle with QRS more than or equal to 150 milliseconds, you should jump and give a CRT. That's class 1. So that's one major change which has come in the latest guidelines. That's first. Second, if we were to look at infiltrative disorders, well, we understand that infiltrative disorders are all around us. We haven't picked them up because we didn't have the modality enough. Today, we look for them, we search them, we identify them. So much so, we have the pyrophosphate bone scan available for amyloidosis now. Treatment is expensive, but we have the treatment available today. So we are aggressively doing cardiac MRIs, and in patients who have infiltrative disorders, our threshold for pacing or defibrillator should be lower because they have high incidence of sudden cardiac death. If you were to talk of pacing in TAVR when it began, thankfully I am in an institute where TAVRs were adopted early, and at that point in time we didn't have clarity. Anybody who developed post-TAVR, remember in TAVR we put the valve near the aortic valve. That's the place the left bundle is going. If anybody who developed left bundle branch block, we went ahead and gave a pacemaker. Today we don't do that. Today we follow them carefully. If a patient post-TAVR develops alternating bundle branch block, we give a pacemaker. Develops complete heart block, we give a pacemaker. Otherwise we follow them on holters. If you were to look at pacing in syncope, what has changed most dramatically is you want to give dual chamber pacemakers to all patients, even for those who have sinus node disease. So dual chamber pacing is the modality of choice in all pacemakers.
So, very well said ma'am. Now talking about the MSP, multi-site pacing for non-responders, that is probably not the correct term. Probably it's a misnomer. They said, years back, they said non-responders to CRT is about 30%. That's not true. So probably CRT will respond. This modality will respond in all patients. It modifies, the risk, or the probably, modifies the, the heart failure, aggravation by probably correcting the conduction abnormalities. So, little word about the MSP.
So, let me tell you about multi-site pacing. Actually meant if you paced in several pointers within the heart. That's as simple as that. Now, it can be placing 2 leads in the right atrium. It can be placing 2 leads in the right ventricle. It can be placing 2 leads in the left ventricle coronary sinus. It can be multi-site pacing within the ventricle with single lead but quadripolar. So what we have learned, which you already answered, if you identify the right patient, meaning thereby heart failure, EF less than 35%, left bundle branch block, wide QRS, and if the patient does not have a significant mitral regurgitation, does not have had a large scar burden, you take this patient to the cath lab, position the lead well with a quadripolar lead. Today we do all quadripolar leads. The success of this pacing modality of multi-site pacing is significantly high. The non-responder rate is coming down steadily if you identify the right patient, give the right device.
Right. So you talked a lot about left bundle branch block. So would you say people above the age of 60 probably signifies cardiovascular disease? Why I said that was, probably in one of the landmark cardiology studies it said that 89% of left bundle branch block had subsequent diagnosis with severe cardiovascular disease. What do you say, ma'am?
So I mean all of us are senior in this group. So let me not say beyond 60 is equal to developing cardiovascular disease. I think cardiovascular disease is a disease of the vascular bed, and inherently that is something which is passed on genetically, and part of it we buy it in our life's journey by getting the lifestyle disease. So it rests upon us to protect ourselves from developing cardiovascular disease. Now, to answer the association of left bundle branch block with cardiovascular disease, well, it is very clear, and as you said, patients who have left bundle branch block, even with normal ventricular function, we must aggressively look, does the patient have any kind of cardiomyopathy, be it ischemic or non-ischemic. The same does not hold true for right bundle branch block. Right bundle branch block is a benign problem, but a left bundle branch block is sine qua non, that there is something inherently happening much more.
So ma'am, in recent years, some evidence suggests that the patients with reduced left ventricular ejection fraction with permanent pacemakers have an increased risk of heart failure due to pacemaker-induced left bundle branch block. So that's why most experts like you probably recommend CRT now.
So it has been noted that if your patient has a dual chamber pacemaker and if the patient is requiring ventricular pacing of more than 40%, in fact it's becoming more aggressive if the patient is requiring pacing even more than 20%. Although the guidelines are still on 40%, if your patient is requiring RV pacing of more than 40%, there is a chance that 5 to 10% of them will land up in what I call PICM, pacing induced cardiomyopathy. Now, whenever you have, if you were to offer your patient of normal LV function to me to give a pacemaker, I will not go ahead and say CRT for 55%. I will give a dual chamber pacemaker, but I will do septal pacing. If a patient has compromised ejection fraction between 35 to 50%, I may want to do conduction system pacing. But anybody who has EF less than 35%, I will tell you that I want to do a CRT. That's what the guidelines tell us.
So, ma'am, my last three questions.
I think people are saying make it the last.
Okay, second last. So, you talked about SGLT2 inhibitors. See, they would probably, correct your heart failure, improve your ejection fraction from 20 to 40%. But no drug till today can modify or probably correct the dyschrony. No drug invented which could correct the dyschrony, and so the CRT is there. Now, three things. Underutilization of CRT is really a serious problem, especially in our country. Number two, non-progression of heart failure is regarded to be an effect of CRT. And number three would be pacing is the really only thing which would treat conduction abnormalities. Now, on a lighter vein, ma'am, my last question. Heart rhythm, 28th April 2022 at San Francisco. Were you there? Okay, wonderful. So, this was also published in JACC, Clinical Electrophysiology, and on 29th of April 2022, and what it said was that women 48% of the women took medicine as their subject or became medical graduates. Out of them, 24% took up cardiology, and out of those, a woeful 6% went into electrophysiology. Why? Is it because of the long learning curve? Is it because of fluoroscopy, probably radiation, or is it because of the old boys club, ma'am?
Well,
You should be proud.
Yeah, but cardiology in itself is not an easy specialty to be in. You have to have the passion for the subject to sustain it there. So first, we are all aware that cardiology is daunting. After your cardiology, interventional cardiology is a specialty which is not adopted by women as much, but it's changing, let me tell you that. And electrophysiology is furthermore challenging because of its longer learning curve, A. Second, radiation, as you rightly brought out, has its issues of childbirth, and we have to always wear the lead aprons. I think the frame of the woman is smaller, the bony structure is lesser, the lead apron itself is about 5 to 10 kilos. You have to have a very robust skeletal system to take it on, you have to exercise well. And I think these are the challenges, and let me tell you from my own taken upon myself to promote women in electrophysiology, and we have made a group all over the country with about 10 of us, and to promote it, and I seek your thoughts and opinions, and if you have any of your own daughters who's pursuing medicine and cardiology, I'm very happy to engage and help. What we have thought, one of the best ideas I have, and I'll be happy if all of you also share, is to bring in medical students, MD medicine students or cardiology students into my cath lab and showcase to them in a week. Let's see this, we make them stay in Surya, we make them feel good about it. We showcase what an electrophysiology lab actually we can do. When they see a woman practicing, when they see a woman delivering, I think they will have the confidence that I can do it better. So these are small steps which we are taking, and it rests upon you. Dr. Chauhan just said that you probably don't have confidence on me yet. So I think it rests upon all of you to have confidence that a woman electrophysiologist only can do better than a male electrophysiologist.
So ma'am, do you remember my last case, Mr. Naveen Jori, who had a DCM, and you did a CRT, you gave a CRT, he was doing very well, his quality of life improved tremendously. Unfortunately, we lost him due to COVID-19 pneumonia last year. Thank you, ma'am.
Very good. Shubham, you had a question.
Well, good evening, ma'am. I am Dr. Shubham Vatsya, and it was an inspirational.
Dr. Shubham Vats is a consulting gastroenterologist, DM Gastro.
Yeah, so I'm a gastroenterologist. I work at Fortis Scots, but in Faridabad, and I'm based in South Delhi. So your talk was pretty, what you call, academically very inspirational. It reminded me of my days at MAMC of MD Medicine when I used to listen to Dr. Vijay Trihan, who's in itself a stalwart in your field. Ma'am, I just had a basic question. It reminded me of my MD days. We had a long question on CRT in our MD exit that was around a decade ago. So if you have a patient who has an acute onset dyspnea, has pulmonary edema, comes out to be ischemic cardiomyopathy, LVF with an ejection fraction of 20%, on an angio has a triple vessel disease, and has a sort of not a regular rhythm. Would you think that before we go ahead with anything else, a regular rhythm would be more important? Because it is a chronic condition now, and ejection fraction is 20%, patient is responding to diuretics, patient is responding to what you call all the normal heart failure management, but it is HFrEF. So what do you think should be done in such a case? I've had quite a few patients like these, which I've been like confused and
I'm very glad you bring that up. So whenever we have CAD and LV dysfunction and triple vessel disease or double vessel disease, the first thing is we have to identify if there's any ischemia, residual ischemia. So you must do a thallium scan. The thallium scan will tell us, a resting thallium will tell us if there's any viability, and a stress thallium will tell us if there's any ischemia ongoing. So if there is none, I am understanding there is none, you've excluded ischemia because the patient should never be deprived revascularization. So you've excluded ischemia. Now the patient is responding to your therapy, has a white QRS, it's the time that you should enter in and begin to talk, because otherwise you may just lose him to a VT. So anybody who has CAD, who has LV dysfunction with a white QRS, it's time to engage and tell him that you need a device early rather than wait.
I'll end it with this. So what do you think, in my old days, like brown bond, I don't know, you might remember better, isn't a PET better than a thallium for...
Viability?
Yeah.
So you can do either of the modalities. Why do we prefer thallium? Thallium also tells us the functional capacity of a patient. So when we do a thallium scan, stress thallium scan, in a compromised LV, we make him walk on a modified bruise. It gives us a functional capacity. How much did he walk? In how many minutes did he achieve his target heart rate? There are patients who may achieve in 2 minutes. They come back to us and we tell you, you have no functional capacity, exercise better. While a PET is a very good modality to pick up viability, but tells us nothing about the functional capacity.
Thank you so much, ma'am. Thank you so much.
Dr. Shubham, some good questions. I think you might have done DM cardio as well.
I was trained by Dr. Trehan in my MD days in MAMC.
I'm glad he did. He's very bright.
Yeah. I think if you learn how to put in a pacemaker for man,
I'm happy doing
ERCPs.
I'm happy doing ERCPs, and
you are still a good candidate. And I know the answer now. CRT, who is the candidate? Yes, ma'am. A wonderful session, ma'am, and some wonderful questioning by Dr. Kalra and Dr. Tulsi sir. Ma'am, we had this terrible pandemic of COVID-19, and we know there have been some very serious issues with the heart with COVID. What has been your experience with COVID-19 pandemic? And were you called in more often to sort out issues during this pandemic? And what were those issues regarding electrophysiology in COVID-19 pandemic?
Yeah. I'm on the side of the audience. We'll, I think, make this the last question so everybody can rest easy. Yes. So, but this is a very, very important question and very valid to all of us. And the problem of post-COVID complications is still ongoing. So let me tell you that in the European world, post-COVID, they did cardiac MRI for patients, for all patients. They found that the involvement of the myocardium was noted in as many as 60 to 70% of people. So the virus was not forgiving for any organ. It went and hit all the organs. So if you did an MRI, you have myocarditis. Thankfully, it has not resulted in as much of dilated cardiomyopathy, what happens in myocarditis. However, as electrophysiologists, the biggest problem that we see post-COVID is palpitations. There has been, during the COVID, I saw a lot of sinus bradycardia, and we kept following them with Holters. But now, they keep coming back with palpitations. So any patients coming in, we ask, do you have COVID? The answer is yes. It could have been 6 months to 1 year back, but we do Holters. We see that they have sinus tachycardias ongoing. Thankfully, we are not seeing as many ventricular arrhythmias. We have had few patients who have come with dilated cardiomyopathy also related post-COVID. So I think the spectrum is very large. It has been an unforgiving virus, affected many organs. So if your COVID patient, post-COVID complication comes and complains of palpitations, it's a good idea to at least do a Holter and an echocardiogram. That's the least you should do.
Thank you very much, ma'am.
Yeah, right behind you.
Is there any age incidence in these tachycardias, the younger group? And can you be relating it to just anxiety on these parts because you had COVID?
Yeah, so I think that's a very valid point. So COVID has left us also very, what shall I say, panic-stricken. People who saw their parents go away. I mean, we are all aware what all happened during that time. So that's why I say that it's very utilization of diagnostics, judicious use, but just sitting back and seeing and giving the patient the comfort that you're fine by doing these simple non-invasive tests. It could be just anxiety, which you will know how the patient's heart rate is behaving in 24 hours. If the patient actually has a problem, even during the night he will remain tachycardic. But if the patient doesn't have a real problem, his night rates and rest rates will be eased off. So that's a very valid point, that you should try to discern and differentiate between an anxious patient, a panic-stricken patient, from an organic disease which has affected the sinus node.
Ma'am, just the last question.
Oh my goodness.
Just the last question. No, just the last
Not
question.
for me. I'm okay. I can sit all night long.
Just the last question, ma'am. We understand that there is an issue of anxiety associated with COVID, and we had a lot of patients who had tachycardia post-COVID, despite having been treated adequately. Is there an issue with tachycardia-induced cardiomyopathy?
Yes. So there is something called tachycardia-induced cardiomyopathy, but it is never seen or barely ever noted with sinus tachycardia-induced cardiomyopathy. It is often seen with atrial tachycardias, atrial flutters and atrial fibrillation. That's what we call tachycardia-induced cardiomyopathy. With sinus tachycardia, we generally don't see. The only place we may see is inappropriate sinus tachycardia if the patient continues to remain, for which we have different modalities, but thankfully it's in a very minor population.
Right, ma'am. Friends, we come to the conclusion of this important CME. I would like Dr. M L Kalra sir to summarize it for the backbenchers who were sleeping. I just saw them. Once they wake up from their obstructive sleep apnea syndrome, Dr. Kalra will summarize the CME for them.
So, I think everybody will agree it was one of the best CME on this topic. None other than Dr. Aparna. Just a comment, are you using thyroid guard also when you are using lead apron, or it is?
Yeah, I think, thank you for asking that question. I use a head cap which protects my head. I use a thyroid collar. I use the entire lead apron, and in fact, I'm glad you bring it out. I also have to start using lead glasses, otherwise I'll very soon have cataract. And we try to make sure that the radiation, the fluoroscopy is at the lowest frames per second to protect ourselves as well as the patient. And every case I drum this into my fellow, that you are a nobody for the hospital when you are sick. Each one of us must, I think, remember that. Our value is only as long as we are healthy and kicking. Otherwise, we are no value. We are only of value to our families.